Okay, then I'd like to call the Neighbors of Dunn County Standing Committee meeting to order. And call the roll. It seems that everybody's here except Supervisor Laufer. And next up, approval of the minutes. I hope you all had a chance to look at the minutes. Okay, Supervisor Lyon moved and Supervisor Story second. All in favor? Aye. Okay. At that, I just want to mention that we're supposed to be doing a little bit different method of passing resolutions and doing different kinds of things. We don't do too many here, but the idea is that we clarify or explain what a resolution is, or this case, and then after clarification, someone would make a motion. Before there's any discussion, make a motion, and then discussion would occur. And that's what's been happening at the county board meeting. The thing is we're all used to having a first and a second and voting yes. It's much more important now to recognize we can vote no, because someone might make a proposal, first and second, we get and discuss it. We've got to have a little different mindset now as far as, okay, just because the proposal doesn't mean it's a yes vote. It's just a way to get it on the table so we can talk about it. And I didn't do that with the approval of the minutes. I didn't think it was worth it. But just keep that in mind. We don't have much here, but if you're on another committee or at the board. No, I didn't. Yeah. Yeah. I forgot that part. I should have asked that part. Yeah. Is there any public comment, Carmen?
Dr. Brown has anything?
Just a question that
Right here.
the other county homes in the state that were sort of headed in the direction of being sold, have they continued in that direction? Have we lost more county homes?
I don't have any updated information about any specific homes. I do know that there were at least 2 that were having lawsuits regarding the process, and I believe those are ongoing. So I don't think they actually went through with the sales at this point, but I don't have any specifics about any of the homes, but I can get that for the next meeting.
We'll wait just a second. Supervisor Laufer is here now. Welcome, Tim. And Chris. We just approved the minutes, Supervisor Laufer, and there is no public comment. And then number 5, at the request of the chair, payer source of Neighbors of Dunn County. Let me give you a little background on number 5. I've asked Carmen to do kind of a primer on different sections of things that we need to know as supervisors on the committee. So today is just the first of many. And I'm thinking, do you have a handout, Julie, eventually? Well, what you'll want to do is keep her handouts, because at the end, when we're finished here, you're going to have a handout. It's almost like if you're a new person, and you're going to have it for the future, it explains the major items that we've been asking about, and I've been asking about for several years. And I know some of the things she's going to talk about today, I know, and most of them I've probably forgotten. So this is going to happen most times unless we have a full agenda. So keep the handouts, keep them in one spot. And these are questions she's been kind enough to answer. They're ones that I just sat down and thought, well, what are the things I've been asking about all these years and what other people have been asking about? So you're going to get this quite often. So at the request of the chair, payer source of NDC, Carmen?
All right. So as Supervisor Kinnear mentioned, I do have a handout, but he did request that I go over it first and then hand it out. The handout will go into kind of the basics of things that you need to know about the different payer sources for NDC. I'll explain them a little bit more in depth verbally, but it does cover kind of the need to knows of all of the different payer sources. So NDC has many different payer sources. I'm going to go over the main ones. There are always some anomalies that we might have something different, but these are the ones that pay for 99% of our residents' stay there. So the most common payer source is Medicaid. So that is medical assistance. That is a state program. Medicaid is our primary payer source of most skilled nursing facilities, including NDC. On any given point, we about have 70% of our residents that are on Medicaid or medical assistance. Those are synonyms. If you hear either Medicaid or medical assistance, they mean the same thing. The Medicaid program is partially funded by the state and partially funded by the federal government. It is decided how it gets dispersed through the state, but it does receive some federal funding as well. Medicaid is a program that requires the participants to meet both medical and financial eligibility. That meaning they are required to need our care as well as need the help for financial assistance. The Medicaid application process is something that can be done either prior to being admitted to the facility or while they're already at the facility if they start on a different payer source and then need medical assistance later on. This is something that we also assist with residents need medical assistance and aren't on medical assistance. We do help them with the process to apply for medical assistance. Historically, Medicaid has been a lower payer source. For years and years, we have been fighting for better payment from the Medicaid system. That did change in the last biennial budget. And now we are getting more money for Medicaid than we had in the past. And now it is actually one of our better payer sources. That will hopefully continue. We will know in July if that does continue. The Medicaid rates are set through what is called cost reporting, which will actually probably be one of the topics at another point. So I'm not going to go into too much detail about cost reporting because that's very specific. But that is how our Medicaid rates are set, and it is based on our residents' needs. Medicaid is an all-inclusive payment source, so meaning we don't charge separately for different things. The rate goes to everything that we provide for the residents. The next payment source is Medicare Part A. Medicare Part A is the primary payer source for residents on rehabilitation stays. So short-term rehab stays, or if a resident who is already with us that goes out to the hospital for any given reason, they have a qualifying stay, which is 3 days, 3 overnights at the hospital, they can come back to us on a Medicare Part A stay. The maximum amount of days that a resident can be on a Medicare A stay is 100. Many of our residents, actually most residents, do not reach 100 days. It is not guaranteed on Medicare stays, but it is the maximum amount of days that Medicare will pay for a stay. That being said, they can use some of their days in another facility. It does not start over when they come to us. So if a resident is at another nursing home or a swing bed at a hospital, they are using Medicare Part A stay days, and then they come to us with only whatever they have remaining of the 100 days for their qualifying event. Medicare is paid for in a way that is also all-inclusive, like Medicaid. So we do not charge separately for things like wound care supplies, minor procedures, pharmacy bills, things like that. It is all included in the Medicare Part A rate that we get from Medicare. Medicare is a fully funded from the federal government. So that is what makes it partially also different from Medicaid is it's not state funded, it is federally funded. Medicare Part A's payer system is extremely detailed and cumbersome. So there's a lot of different things that go into each rate. Each of our rates for our residents are different. That is based on their need, which is determined through the MDS or the minimum data set assessments. So you've heard me talk about the MDS before. It is a lot of questions and assessments that are done for all residents, whether they're on Medicare or Medicaid or even private pay. We do them for everybody. It gives us the basic assessment of what a resident's care needs and costs. And that's how we get rates for our payment systems, but Medicare's is directly related to what the person needs. Like I said, it is also all-inclusive. So we do not bill out anything, and we cannot bill out anything to the residents. So if they need something that's more expensive, say they have a high cost drug, we pay for it as part, and we get paid the same rate. It does not alter. Most of the payments for Medicare are short term. So we might have people there for 3 days. We might have them there for 20 days, but that max is 100. Medicare also decreases the amount they pay for each resident by how long they are there. So at day 1, they pay the most for them. That changes at day 3. It also changes at day 7, and then changes at day 21. At day 21, Medicare also only pays a portion of the stay, and then residents need to either utilize supplemental insurance coverage for the other portion of the stay or pay privately for that other portion. So that is the only caveat of where we then do bill something other than Medicare, but it's not one-offs, it's a percentage. So it's an 80-20 percentage. Medicare gives us our rates for each person. It is based on the needs, and then it also is based on their qualifications. So therapy is the number one qualifying thing that qualifies people for Medicare. The majority of our residents on Medicare Part A stays are there due to therapy coverage. So our therapy department either works with physical therapy, occupational therapy, or speech therapy, or all three. They typically determine when someone is ready to be discharged from therapy and then discharged from Medicare A. In some occasions, nursing can actually cover a skilled need for a stay. That's very rare, but it does happen. One example of that would be daily wound dressing changes could also qualify for a Part A stay, even if therapy is done. Most of our residents that are on Part A stays would either transition to another household or back to their regular payment system. Once they are done, they might become Medicaid, they might become private pay, or they might discharge home. Typically, we have about 10 to 20 residents on Medicare Part A stays. This fluctuates greatly. It fluctuates based on how many people we're admitting to our short-term rehab households. It can also be based on how many people we've had sent out to the hospital recently. So even if they're a long-term care person that goes out to the hospital, they might come back to us and be on a Med A stay for a couple of weeks while they receive therapy. So this really does fluctuate regularly, but it is also one of our best payer sources, so that pays us the most per resident. That being said, most of our Medicare residents are also the most costly to care for. So it does kind of even out a little bit, but we do get paid the highest rate for Medicare Part A. The next payment source is Medicare Advantage plans. So these are very similar to Medicare Part A. So they cover in the same way that they are for short-term rehab stays. So typically this is someone who has waived their Medicare Part A benefit and signed up for a Medicare Advantage plan. So these are insurance companies that are acting like Medicare. So we sometimes refer to them as like Med A when we're doing reports, because we do the same thing for them. It is short-term rehab. These people are on therapy, and it pretty much acts the same as Medicare. That being said, there are some differences. We do have to have contracts with these companies so that we are considered in-network. Just like when you go to the clinic or the hospital and you have your insurance company, whatever insurance company you hold for your regular healthcare insurance, you have to look and see who's in-network or not. That's the same thing for Medicare Advantage plans. So we have contracts with several of them. The majority of our contracts with Medicare Advantage plans comes through the Leading Choice Network, which is an organization that we belong to that is both financially and clinically integrated. So what that means is that we provide things to this organization that shows that we are both financially integrated with them as well as clinically. So we basically prove that we're a good facility, that we're taking good quality measures, and then they take all of the facilities that do this with them and negotiate contracts for all of us. So we pay for this service to be members, but they do a lot of the legwork in terms of negotiating contracts with insurance companies. So like the big ones, Humana, United Healthcare, all of those that you've heard of. Leading Choice does the contract for all of the facilities in this network. And then we typically get higher rates because we're proving that we are a good facility, and it's a bunch of facilities working together to show those metrics. One of the things that makes Medicare Advantage plans different from Medicare is that our staff and our therapy staff are not the ones typically making the decision when Medicare or when the covered stay is over. In an insurance company platform, the insurance company is making that decision. So that does add some added challenges. The insurance company do extremely regular reviews of each of the residents who are on their plan to see, do they really need nursing home care? We sometimes don't agree with those reviews, and it does add quite a bit of administrative time for the resident, the families, and NDC staff to file appeals when the insurance company says we're ending the Medicare Part A Medicare Advantage plan stay. We typically do win appeals when we submit them. I will say when we win an appeal, we typically get another review and denial within a day or two. So it just becomes a continuous process. This process can extend all the way to an ALJ judge. If a family continues to want to appeal, we help them and we go through that process. And we've had 2 times in the recent history that we've got into an ALJ judge and have won both of those to get the stays covered. So it's a lot of process and a lot of work. But as many people know, insurance companies don't love to pay for things. So they do denials, and we go through that process whenever we need to. Um, administrative law judge. Sorry, you stumped me there for a second. So they're judges that are there to kind of, they're third parties. So to basically review what we're doing, what the insurance company says, and then they make a decision basically whenever we cannot come to an agreement of it. Coincidentally, both times that this has happened, the insurance company comes on the call with the judge and basically says it's okay, we'll approve it. So in my opinion, they make the denials because they don't think people are going to go through the process. And we do, because we want the people's stays covered, because we truly think they need it. The next bucket here is private pay. So private pay residents are people who pay individually for their care. These are typically long-term care people. It can happen that people that do get denials from Medicare Advantage plans could pay privately and then still be a short-term person. That is very uncommon, as that is very expensive because then they're paying for therapy privately as well. So that's not super common, but it can happen. But typically they are long-term care people. This is more of an a la carte service versus the all-inclusive like Medicare and Medicaid. So we set room and board rate, so that is the same for everybody. We adjust that every year. We talk about that at this committee during budgeting season of what we are going to have that rate be. It goes up January 1 typically. And that rate is set. So that covers room and board and all of the general things that we have. And then they would also be charged additionally for anything specific they need. So medications would be a big example. They get their own pharmacy bill because that is different for everybody. If someone is on oxygen, that could be an added cost. If someone is on a high cost wound care, that would be an added cost. So it really is more of an a la carte. But the basic services that we provide, nursing care, the food, room and board, all of that is included in that daily rate. A lot of our residents that come to us on private pay do eventually transition to another payer source, typically Medicaid. So that does happen, but they might come to us first on private pay privately for a few months, a year, and then transition to Medicaid as needed based on their financial status. The private pay census varies drastically. because it does depend on how long people are on private pay. We don't make decisions for admissions based on payer source. So it's kind of luck of the draw of who our admissions are, if they're going to be private pay, Medicaid, or another payment source. And then our final major payment source is Veterans Affairs, so VA. The VA has contracts with limited facilities in each county. The Neighbors is the only facility in Dunn County that has a VA contract. So it's very specific. There's typically only one in each county. We have kind of a special exemption of all three of our facilities are contracted with VA because we're one entity, but it's normally one entity per county. The VA is an interesting payment source because we do not make the decision if someone is VA qualified. So not all veterans qualify for VA coverage for skilled nursing facilities. It is determined by the VA. So anytime we get a referral that is someone who was a veteran, that's one of the basic questions. We then contact the VA and say, can you please check eligibility? So then the VA will tell us if the person is eligible for a VA contract, and it is typically based on service connection. So if their service is part of the reason they need care, that's typically why they're covered. So if whatever ailment they have that they need our care is directly related to their service, then that is how they determine eligibility. So the VA does that, then they tell us if they're eligible, and then that's how we determine that they are a VA resident. The VA has very specific standards as well as billing things. So one example is how many doctor's visits get approved. So they have a standard of how often their people see the doctor. That's automatically covered. If they need to see a doctor an extra time, we have to do a request for that. So there's some added nuances to the VA contracts. In addition to the service connection, one of the other things that it is commonly covered by the VA is if we have veterans on hospice. So when we have a high veterans census, it's typically most of them are on hospice. It's not a guarantee, but that is a commonly covered service by the VA. It's not always covered. I think we've had maybe one or two cases that we've had someone on hospice that the VA didn't cover if they were a veteran, but it's very, very common that they do. So those are the main payer sources. There are others that are kind of one-offs. We have very few long-term care insurance, and each of those is very, very different depending on the insurance. So I didn't want to go into specifics about that. Another one is MCOs, which is managed care organizations. That would be like your Inclusas, if you've ever heard of that. They act as if Medicaid for nursing homes. They just have some extra services, but we bill them the same as Medicaid. They're required by the state to pay us the same rate as Medicaid, so it's not much different. So there are some nuances of other ones, but those are the major payer sources.
So let that sink in a little bit, and we'll pass these out. And you can look at them. We're going to take a little time here, look them over and see if you had some questions that you wanted to ask about. So. How many you made, Carmen? 10. Oh, okay. Steve, you want one? Supervisor Lyon, do you have a comment or question?
I have a question. Medicaid is dependent on financial eligibility now. So when they're looking at financial ability, they're looking at the financial resources that a patient has. I'm just recalling, what my in-laws went through. And so that's the point at which that's where, as an individual, you want to protect your assets, so that they're not drawn down for your heirs. And that's where the private pay comes in, where that would be required.
Mhm.
Okay.
Yeah, so if someone is not eligible for Medicaid, they're required to pay privately.
Mhm.
And then they do the Medicaid application, and Medicaid as a system decides if they're eligible or not.
Mhm.
So we don't make that determination. We just check eligibility
Mhm.
in the system. And then basically Medicaid decides if they're eligible for it. What I think you're getting at is the look back period for spend down.
Mhm.
So Medicaid will do a look back to see if any money that has been spent down within the past 7 years. And then that money they would be basically on the hook for. So if you've spent down money during that look back period, so say someone gave their child $50,000 a year before they needed Medicaid,
Mhm.
they would not be eligible until they paid $50,000, and then because it was part of that look back period.
Okay.
So those are called divestments. So
Mhm.
that does happen, is that someone might be on a divestment and then Medicaid is not going to pay until that is either paid back or paid for to the facility. So that is an eligibility thing. That is one of the primary reasons that we do not accept Medicaid pending. So some facilities do accept what's called Medicaid pending. So we get a referral. They say we have sent in our Medicaid application, and we can check on the Medicaid system and it'll say pending. We do not accept that because that's what we might get into, is that someone is pending. They haven't been
Mhm.
approved yet. We accept them into the nursing home and they do not get approved because they divested money, but they gave it to their second cousin who's now ran away, and we can't bill the second cousin.
Mhm.
And then we have someone that doesn't have money left and doesn't have eligibility in the Medicaid system. So yeah, we do not accept Medicaid pending for that reason.
Okay.
Mm.
Thank you.
Supervisor Laufer.
Yes, Carmen, if somebody does do what you just described there, give it to their cousin, they run away or whatever, is it the state or federal government's responsibility to go after that person then to recover that, or you don't just get left on the hook for,
If we did have someone that was in the facility that did that, we would be on the hook for that
it
money.
would be?
Mhm. Or their care. So part of that is that in that case, we could do a 30-day notice of discharge, because non-payment is one of the reasons we can discharge someone from the facility. That being said, they have to have a safe place to go. So part of the involuntary discharge process is we have to find them somewhere to go. If they don't have a payer source, no one's taking them. So then we end up with them anyways. So if that does happen, if they say they admit to us on private pay, they've been paying us, they divest money, they apply for Medicaid, they no longer have the money, that's where we would get in those situations. But we avoid them on the forefront if someone is pending for Medicaid already. It can happen if someone comes to us on private pay and then divests money. And it has happened. That has been some of our bigger write-offs have been because of that situation.
Supervisor Wolf.
Yes, thank you. More of a comment to the other supervisors than to Carmen. From personal experience, my suggestion would be to start a trust, get financial advice as soon as possible. The longer you have had that in place, the less chance you have of losing everything you have to give to your heirs by medical or other reasons. There's several reasons to do that. If you have anything you want to protect, get it done as soon as you can. Thank you.
Supervisor Story?
I was just going to say, though, that I believe that part of qualifying for Medicaid does have something to do with protection of the home property. There's certain things you take into consideration, I believe.
If there's a living spouse.
There's
So,
a living spouse.
If there's a living spouse, it's called spousal impoverishment. So if someone needs medical assistance, they do not have the extra money, they do not take the home or a vehicle away from a living spouse. That being said, if there is not a living spouse, they would take the property into account in terms of eligibility. And if there is a property still, they probably will not qualify unless the property is up for sale. So that does happen, that we've been waiting for properties to go up for sale. The caveat is the living spouse and spousal impoverishment. They will not make someone in the community be homeless to pay for the nursing home.
And does your paperwork, though, have some kind of a line there that says that they claim that they do not have the following or whatever, that they've taken care of that, or that they haven't taken any of the funds and given them away, or, to where there's some kind of a promise or truth so that if you did want to then go after the property or whatever, you're able to do so more easily?
Our paperwork does not have anything in that, but the medical assistance paperwork, I'm not sure what's all in there, but because that's done directly with the Medicaid system. Our admission agreement does not have something like that, and I believe it actually legally cannot. We
Okay.
can't require someone to disclose their finances.
Oh, really? Okay. Thank you.
Go ahead.
Carmen, and I know this really sounds, I just don't, I come from a family that's really been blessed with health, and so I just haven't had many family members that have been in nursing homes so I'm just so ignorant on this stuff. And you mentioned the hospice program. What actually is that compared to, no, like with the VA, if there's somebody on hospice compared to a person that is not on hospice, what is hospice and how does that,
Sure.
um,
So hospice is an added service. So whenever we have someone on hospice, they might be VA hospice or they could be any payment source hospice. So there's Medicaid hospice, private pay hospice, and VA hospice. Medicare and Medicare Advantage plans do not have hospice included. It's long-term people. Hospice basically means that there is a likelihood that the person will pass away within 6 months. You have to qualify for hospice. Residents have to request hospice or their families. So we have contracts with several hospice companies. It is an outside entity that comes in and has different services. So it is in addition to our services. That being said, we still do the same thing we do for everybody else. And then there's a company that comes in and provides other services. So that might be an extra shower during the week. It might be extra assistance with different things. Chaplain services come in through hospice. It's basically end of life care that is additional services. And then there's just different payment sources for them as well. And it is typically one of the things that helps qualify veterans. So they might be private pay all the way up until, because their reason for being with us has no connection to their service. They might be private pay even though they're a veteran. Then they go on hospice. We will resend that off to the VA to see, and typically it is covered. Not always, but typically. So it's basically end of life care with a prognosis of 6 months or less. Each hospice company has a different way of assessing if they're going to put someone on hospice services. A lot of times it is related to significant weight loss, general decline, decline in their activities of daily living, how much help they need, things like that. And then the hospice companies come in at that point.
Supervisor Love, were you kind of asking about what kind of services? I know Carmen just mentioned some. It's the same services as you'd receive at home.
Mhm.
It could be, like she said, somebody coming in for a massage or music, or a pastor coming in, all the different kinds of things. And one thing about the neighbors is I knew someone in there who should have been on hospice, but the person that was in charge of their health wouldn't allow it. So the neighbors actually did extra stuff. I mean, they said, well, we're gonna make sure this person gets this, even if. So, neighbors does a really good job.
So you do the same thing as hospice. It's just that that's included within the,
Somewhat, yeah. So we have something called comfort cares. So hospice is basically used for end of life care where we are just keeping people comfortable. Hospice is in way to have the end of life be as comfortable as possible without doing any extraordinary measures, things like that. If there's a resident that does not, the family or the resident does not want to be on hospice, I think there is some stigma to the word hospice that people think that that means they're going to die immediately, which isn't true. We've had people on hospice for 5+ years. It just means that there is a likelihood that they could die in 6 months or less. And then they get renewed for more years, things like that. So comfort cares is something that we do. It just means that we remove all the extra stuff. So they're not taking 17 meds a day that are extra. We're not having them take random vitamins and things like that. We're just keeping them comfortable. And then we will add extra services if it means an extra shower or we have the chaplain come in. We have a lot of volunteers that come in and do things like visiting angels and stuff like that too. So it is a little bit different, but we try our best to accommodate even if a family isn't ready for hospice yet.
thank you.
Supervisor Lyon?
When my husband was diagnosed with cancer, he went into something called palliative care. Would that be the same as comfort care?
It's similar. So palliative care and hospice kind of go hand in hand. It's palliative care is like a step below hospice in terms of services.
Okay.
So yeah, it's similar to comfort care.
Yeah, I remember they provided that provided, the hospital bed in our home and
Yes,
things
and
like that.
And hospice does do that as well. So they will provide, if a resident is on hospice, they will provide different equipment sometimes. So they might provide their own oxygen tanks. They might provide a specific mattress or
Right.
mat for a wheelchair, things like that, in addition to what we have at the facility too.
Thank you.
Supervisor Story?
I
Let's start thinking about kind of wrapping it up and then we can think about these things too.
believe too, though, that we need to be aware that this is also Medicaid or Medicare coverage. It isn't for free, that they have to apply for that, don't they? If they're gonna go into hospice or palliative care.
So hospice can be either Medicaid, VA, or private pay hospice. Medicare does not have hospice because that is short-term rehab stays. But any of our long-term sources will also pay for hospice as well. So it depends on what payment they're on. If they're private pay hospice, they would pay the hospice company directly for the extra services. Medicaid would pay if they're on Medicaid, or if they are VA, the VA pays for that.
And then there are resources through the ADRC that they can access possibly, that might be able to assist in some way.
Let's kind of keep it to our payer sources for right now. And can we kind of wrap it up here, I think? And if we have further questions, we can ask Carmen or we can save it for a different time. The idea is to get us thinking about it, give us a baseline. We're starting to get in the weeds, which is okay too, but keep this thing and any notes that you put on it. And there'll be more to come. And what do you say? We go on to the next part of our agenda. That would be, oh, you get to talk again, Carmen. The Community Mentor Administrator Report A, Quality Assurance Steering Committee updates.
All right. So the rest of my normal report is going to be pretty brief because there wasn't anything out of the norm this month to share in addition to the normal reports. So that's actually why we chose the payer source, knowing that that would be one of the longer discussions. So Quality Assurance Steering Committee, we met as usual a couple weeks ago now. The only thing new to share is that we do have a new pharmacist. I'm not sure if I mentioned this last month because it was kind of happened the same week. So our pharmacist retired. So we will be having a new pharmacist and she will be here this coming month. So next week, I believe, is our next meeting. So that'll be interesting to have a new pharmacist. Mike has been with us for a couple years and he is retired. So we hire our pharmacist through a contract that is also our pharmacy. So all of our medications for our residents come from that pharmacy, and then they also have a consulting pharmacist. So the pharmacist reviews our medications. Normally, the most reviews are on psychotropic medications as well as antibiotics, because those things are looked at by the state. And then also does a general review of basically our responsiveness to any sort of medication changes and things like that. They come to our QA meetings quarterly, so they're also involved in that as well. Any questions on QA? All right. Employee activity report is next, and Chris is online.
Greetings, Chris.
Greetings. Good morning. Can everybody hear me?
Not really.
Better?
Say again?
Can you hear me better now?
Not coming through the mics very well.
No.
Okay. Can you hear me now?
No, Carmen will check on our end. We
Okay.
can hear you, but just barely.
Oh, odd.
Give it a try now, Chris.
Okay. Can you hear me better now?
Yeah, it's a little better. If we're real quiet here and you talk loud, I think we'll get it.
Okay. So for March, the report is in your packet. Quite a brief report. Types of recruitment, the same as we always use. Number of direct hire interviews was 5. Agency interviews was 2. Positions offered 3. Positions accepted 1. We had 3 resignations in the month of March. 1 CNA was college graduation. We had 2 homemakers that had resigned. 1 had retired and 1 just had some school schedule conflicts. So if we go down the open positions, were adjusted as such. We had no work comp lost hours for March, and we had no missed shifts due to COVID positives. So like I said, pretty brief report for March.
Yes, any questions? Anybody on the? Okay, I think then that's good, Chris. What's your just general outlook, Chris, when you look at employment? Is it looking up, down, staying the same?
I think, I don't see it getting a lot worse or a whole lot better. And we still struggle for CNAs like any other facility. We're very good. We're very fortunate to have the licensed staff that we have. As we sit now, we only have 2 agency nurses, 1 LPN, 1 RN. I mean, so it's a positive. We don't really struggle with that. It just remains the CNAs, and that's kind of felt state nationwide. So
Okay, thank you.
you're welcome.
Move on then, Carmen?
Okay. The next is a CNA training program. I do not have any specific updates, just that they're still doing classes. We have had quite a few classes they do like the nighttime training. So the CNA Institute is there in the evening, and then they do their clinicals with our residents, and it's been going smoothly.
Any questions or comments? Yeah, Supervisor Wolf, thank you.
Sorry. Thank you. Current number enrolled? Do you know?
I do not have the current number enrolled. The class size is a max of 8. So that is the max that each class would have. So I'm not sure if they have 8 in the current class or not, because they do all of that themselves. But there is a decent sized group, because they were walking down the hallway the other day, and it's more than a couple. So
Thank you.
mhm.
Oh, yes, Supervisor Laufer.
It's not.
Carmen, are they required to work at the neighbors after completing graduation of that?
No, they are not required to work at the neighbors. So it depends on how it's set up, because if we have an employee that's like a homemaker per se, that we're doing the WIS caregiver program, through the state CNA program with, then they would be required to work at the neighbors to go through that program, but not all of the people that are doing their training at the neighbors are through that program. So they're not required to, but just getting them in the door to do the training there where they're comfortable, it's likely that they would stay then.
Do you know what percentage of graduates that actually stay on with the?
I do not, but
facility?
I can get that number. I know that it hasn't been a huge number. Have had quite a few people that were sponsored by another facility to do the training. So they just look for the closest training. And then they would also then be required to go back to that facility to do the WIS caregiver program. So it's not a huge number that we've had, but making more CNAs wherever they go is a benefit, even if they're not coming to us. So,
Thank you.
okay.
Resident referral, D.
All right, so in your packet is the resident referral report. So we had 109 residents at the beginning of the month. We had 96 referrals, so that number continues to be extremely high. There is just a lack of beds, and there's still people that need places to go. So we're continuing to see referrals from faraway facilities, things like that. And I think everybody's in the same boat of there's only so many people we can take. So we had 16 residents admitted to the facility this month. We had 93 not admitted. Those numbers don't equal the 96 because it does depend on when we hit approve or deny for the referral. So it is always a little bit skewed. The numbers of residents at the end of the month was 115. We had 2 residents transfer to another facility. Those situations were people who came to us because we had an open bed and they wanted to be closer to home. So that does happen. We've had a couple that the reverse of that happened, of we received people from other facilities, and because they came, say they went to Barron, for example, because that was the closest nursing home, and then they ended up coming to us when we had an opening. That goes the other way too. We had 4 deaths this month, and we had 3 discharge home. Our normal referral sources are the Mayo Healthcare System. That continues to be true. Any questions at all? All right.
No, it looks like maybe Scott's on.
Good morning, everyone. The first thing I'll let you know is update on the food service golf cart. We did receive a bid on that in the amount of $19,965. So that would that was the only bid that we got. And moving forward with that, it would take 4 to 6 weeks for delivery of that. They said that there's a possibility that it could come earlier than that, but they are looking at 4 to 6 weeks. We received base trim samples that Brady ordered, took a look at those. Carmen, Brady, and myself looked at the samples, the coloring, and the profile of them, and we selected a color and a style. And so now it's moving forward, getting the RFP ready to get some bids on it and see where we're at there so we can get that project going. Brady and Bob are looking at replacing patio blocks alongside the sidewalks. There were a couple of benches that were along the sidewalks. The patio blocks that they were sitting on are getting in really poor shape. So, and the benches were removed because they were in poor shape. What they're going to do is enlarge the area where it's going to be a concrete pad poured there, and then the benches can be anchored down on that. That way, visitors can sit on a bench and they can have a wheelchair next to the bench. So it'll be a larger area. It'll work a lot better. And then we can anchor the benches down so they don't blow over in the wind or anything like that. I have plans to move forward with applying some weed and feed this summer, or this spring actually, in front of the houses to knock down on some of the dandelions. We've had a pretty good crop of dandelions over the last years, and Carmen and I have discussed that, and we were going to go move forward with that and have have one of my guys out there with a pull behind spreader and putting some weed and feed down, see if we can knock some of that down and get a little better look out there. And then I have contacted a roofer to take a look at a couple of places where the roof, we've identified where a couple leaks are at, one in west building and one in central building. They'll take a look at that, give us their plan of what we can be done to correct it. I know that when we've had other places looked at, it's looks like a flashing issue and an issue when the building was built that they ran valleys right into dormers, and so the water just runs right into spots and it just forces it in and ends up leaking in the building. So we'll look at getting those corrected and get rid of the leaks. Aside from that, everything is running pretty normal.
The one thing I would add about the benches is both benches were actually donated from families. So we got our old benches were in pretty bad shape, and two families made pretty sizable donations after their loved ones passed away. And one was a specific request to replace the benches, and it just worked out. So they will also they have little plaques on them that say in memory of two of the residents. So, and we did get composite wood benches, so hopefully they'll hold up. If any of you have seen the new seating at the band shell, they're from the same company, so they're pretty nice. So we're excited about those.
Thank you, Scott. It doesn't look like there are any questions. And efficient as usual. It's good job. Well, 7, Carmen, that'll be you.
Yes, it will. So as all of you might have seen in one of Chris's weekly emails is Jane Hansen has retired. So she had put in her retirement and then had actually taken vacation for the last 2 weeks. So she is no longer with the county. So she had provided the financials for this meeting prior to her retirement. So those are completed. I will go over them. Going forward, we actually have 2 open positions in NDC finances as the DHS finance department stole one of our people. It's okay. It'll all be fine. She's wonderful, and she has also offered to continue to help since it's not the best timing with Jane's retirement, but we are currently working on filling Carol's position, who had been our lead biller and working in that department, who now has gone over to DHS, and then we'll working on getting Jane's position posted. I met with Sophia and Beata yesterday, as it is a finance position, but very heavily focused on the neighbors. Jane's position also is responsible for some of public health's finances, but very heavy on the neighbors' finances. So we're working collaboratively with myself and the finance department for replacing Jane. But so I will go over the financials. This is for the first quarter of 2025. So this is the first time you are seeing 2025 numbers. In past meetings, we have only talked about 2024, as the county has had an initiative through the finance department to only start doing projections after there's a quarter of a year of data, just because it is a little bit more useful at that point versus every month. So right now, if you look at the neighbors' overall finances sheet, which would be the first one in your packet, that shows 2023 actuals, 2024 actuals, total budgeted for 2025, year to date, and projected. So it does include the actuals from 2024. Those are still unaudited numbers. Our audit has been completed for the neighbors, but they're still working on our cost reports, which will hopefully be submitted this week. So we are working with them still. And then sometime early summer is typically when we do our audit report with the audit firm. So that's an unaudited number is the 1.1 million. Year-to-date actuals is at the 681,942 without depreciation, which is the 566. So that is in the black still. So for the positive, we have less expenses than revenue right now. And then the projected out for 2025. As we are still pretty early in the year, those projections are pretty rough numbers. As we go through the year, those will get more and more accurate, as you saw last year.
Any questions?
Okay.
Nope, looks good, Carmen.
All right. We will then flip, unless you would like me to go over each building.
Let's not.
Okay.
There were no questions.
Perfect. All right. The next is the agency financial report. So that has been updated for this year. So you can see that we are still doing okay with agency. It is still a high expense, but we do try to limit that as much as possible. So the end of 2025 actuals are on there, or the 2025 actuals is $920,000 so far this year. So that is pretty comparable to last year. If you look at the budgeted number, just as a reminder, we only budget the overages of how much we are going to spend over the cost of internal staff, because if we budget the actual cost of agency staff, it ends up double budgeting. So that total budgeted number always looks very small because it is only the amount that it costs us additionally for agency versus internal. You'll also see the nursing staffing report, so that includes NDC nursing staffing and then the total staffing report, which would combine the two, which is really the comparison that we need to look at, is how much are we spending to staff the building with both internal and agency, which is that bottom line. Any questions on staffing at all?
It doesn't appear there is.
Okay, the next page has the senior meals and the depreciation report. So depreciation, we spread out throughout the year, as you're all aware, and then that ends up on the regular financials. And then the senior meals is cost in, cost out, and we try to be as net even as possible. The projected 73,000 is a little bit high. That's just based on the first 3 months, and there's some different things in there. So I would estimate that that would be lower, as last year we made 17,000, or no, sorry, I'm looking at the wrong one. Total actuals for 2024 was only 7,000. So that projected is a little bit skewed. It also does not take into account some of the overhead that we do use for senior meals. So any questions on senior meals?
Nope, let's go on.
Okay, the census report. So goal for 2025 was 82% census. March of 25, we did have 81% census. So we were right on target for what we budgeted, which is what we hope for. So yes, of course, we want to fill the beds and everything, but being on track for what we budgeted is the best we can ask for, because it does help with actually looking at where we're at. So the different bars there show you where people are for payer source. Medicare has been above our targeted line, which is good. That is, like I mentioned earlier, our highest payer source. The one that is higher than normal is VA. That's that blue bar. So that is something that we really have no control over. It just kind of is what it is. So that fluctuates very frequently. Sometimes we only have 1 or 2 people on VA, sometimes we have 10. So that is the census breakdown. Is there any questions about that at all?
Nope, next up.
Okay, and last is the aging report. So you can see the bars break down there. There's quite a bit in those two bottom bars, which is where we want to see numbers. The smaller bars on the top, we want those to be smaller, so that's looking pretty good. I will say that this might increase some with going from 4 staff to 2 staff, so the next month or so might go up, as just there's less staff working on those claims. But the big thing is keeping them in this structure so that those bottom ones could be bigger and the top ones are smaller, because those are things that have been hanging out longer. I do think, for any of you who were on the board the last time that Jane's position was open before Jane was hired, we did struggle with some of our claims management during that time. This time, I think we are in a better spot with that, as the staff that are there have more training and more experience on doing some of these things. Jane's predecessor did a lot of them herself, and there wasn't staff that knew how to do some of the collections and billings and things like that. So we were in a tough spot, and I do not think we are in that spot now. So I think we won't have some of the bigger write-offs that we had last time, would be my guess. So confident that these will not get too big, but you might see a little bit of an increase in some of the shorter term turnarounds. Any questions on the aging report?
Other than we're all aging faster each year, but doesn't look like there are. The next up is the vouchers. And why are a couple of them highlighted? I was curious, way at the top, way in the beginning.
That is a good question.
Is that just to keep us on our toes or?
I think those were ones that were offsetting, because one is in parentheses and one is not. So I'm not sure why Jane would have done that. I believe it would be because they're offsetting. For the contractual consulting, 19, so it was advertising. The advertising bill that we do pay every year is for a company that manages our website. But I think that was already paid out. So I think this might have just been an error,
Oh,
and that's why it's highlighted.
Thanks.
Mhm.
Any other questions about any of the vouchers? Okay, then I would ask for a first and a second to accept the vouchers. The vouchers and financial statements. Okay, Supervisor Wolf moved. Supervisor Lawfer second. This proposal is to accept the vouchers and financial statements. Any discussion or questions? Okay, then we'll call the vote. Aye in favor. Okay, any opposed? It passes. Thank you. And the next thing up on the agenda is next meeting time.
Is May 22nd at 9 a.m. We have an early one because the 1st of May is on a Thursday. So
Okay, thank you. Any announcements? Then we are adjourned.